we just heard about KRAS and then BRAF. I'm going to be talking about EGFR and HER2. Also there are two associated targets very prevalent in lung cancer patients. Those are my disclosures. So today I'm trying to cover ground mostly on the frontline treatment because my colleague, Dr. Agrisingi, was covering the resistant situation. So I'm going to focus on frontline treatment for EGFR, including classical mutation, exon 20, and PEG. And we'll be talking about some of the new development in HER2. EGFR lung cancer now can be classified into 4 different groups, including classical mutation, T790M. Those mutations can be interrogated by treating with the 3rd generation EGFR TKI. In addition, we identified 2 structure function group. One is called the PEG mutation, the other is called exon 20 mutation. Currently, we have a different exon 20 mutation approval I will be discussing, and then PEG mutation, we also start to see new clinical development, potentially new drugs gonna enter the clinic in 2025. Starting with classical mutation, we as a society has been using Tagrisso or the drug name osimertinib for the last 5 years or so based on the FLAURA trial. In that trial, osimertinib frontline treatment for newly diagnosed metastatic EGFR patients achieved a progression-free survival of 18.9 months and overall survival 38 months superior than sequential use of the 1st and the 3rd generation EGFR TKI. In the last 2 years or so, we started to see and start to use FLAURA2, which is osimertinib with chemo combination in the frontline setting. And then we also have FDA approval of amivantamab with lazertinib in the frontline setting. So each of the trials I will go over today, discussing their superiority to the monotherapy osimertinib and also discuss what can be the potential problems associated with additional intensification. This is the trial design for FLAURA2. The trial enrolled about 550 patients and then randomized them to osimertinib with chemotherapy compared to Tagrisso by itself. This is their primary endpoint, showing that the progression-free survival is significantly superior when osimertinib is combined with chemotherapy, both by the investigator assessment and also by the RECIST assessment. In the subgroup analysis, for patients who have EGFR mutation lung cancer upfront have diagnosis of brain metastasis, this chemo plus osimertinib regimen confers significant clinical benefit with a hazard ratio of 0.47. Of course, for patients without brain metastasis, we still see benefit. However, the most significant benefit come from CNS metastasis patient population. This is another busy slide showing additional subgroup analysis. I boxed some of the significant findings in the red box, meaning that EGFR A58R mutation or detectable ctDNA at baseline or TP53 co-mutation, those high risk factors are associated with additional benefit with the use of chemo plus osimertinib. So with this subgroup analysis information in clinic, we start to discuss more with our patients when we see 1 or 2 or even more of those risk factors and then thinking through the risk and the benefit. Up to today, we do not have the overall survival data, but last update of the immature overall survival start to see a separation. Potentially, this regimen can also give patient overall survival. Hopefully, the data will mature in 2025. Around the same time that MARIPOSA trial also is a frontline EGFR mutation study reported positive results. Here, instead of using chemotherapy as an intensification regimen, amivantamab, which is a bispecific antibody, was used as the intensification regimen. So amivantamab with lazertinib, which is also a third-generation EGFR TKI, was offered, and then those groups are randomized to compare to osimertinib monotherapy or lazertinib monotherapy. The total enrollment of this trial is over 1,000 patients. The primary endpoint similarly is progression-free survival, and we also see significant benefit in the amivantamab plus lazertinib arm. In their subgroup analysis, brain metastasis patients also have additional benefit with hazard ratio of 0.69, as well as patients without brain metastasis. In their subgroup analysis, they included patients with liver metastasis here that amivantamab showed significant benefit for patients who have liver metastasis. One discussion point I usually have with my patients is the toxicity of amivantamab with lazertinib in comparison to osimertinib monotherapy, as well as in comparison to OC plus chemotherapy. In this relatively new regimen of AMI plus laser, we start to see grade 3 or higher toxicities around 75%, including skin rash, including hematological toxicities, as well as a DVT risk increase. With that, amivantamab team created a subcutaneous form and reported out a PALOMA-3. Although this formulation is not currently approved in the United States, but subcutaneous amivantamab can remove some of the infusion reaction problems, as well as some of the anticoagulation needs. Furthermore, when we compare the results, we have to say that a couple of weeks earlier, overall survival data was reported to be positive for MARIPOSA trial. By press release, the data will be released next week at ELCC. So we look forward to see how we are changing the landscape and then moving the intensification regimen up front to improve our patient survival.